My name is Nathan Ost. Will be presenting this, as you can see, webinar, Air Quality Health Impacts Associated with Particulate Matter. I've just got my webcam on for a second to say hello. I'll introduce myself. As I just said, I'm a principal consultant in toxicology and health risk assessment, and I will get into the presentation right now. I'm just going to turn my webcam off over here. I begin today by acknowledging the traditional custodians of the land on which we meet today across the world and pay my respects to their elders past and present. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. So as mentioned, my name is Nathan Ost. I work at WSP in Australia. I'm just getting these slides going. In the earth environment, my particular area of expertise is understanding the risks or assessing the risks to human health from chemical and biological hazards. Some example projects was recently we undertook a review of the Australian workplace exposure standard, setting guideline values there for 726 chemicals used across Australia. Bespoke occupational risk assessment. For example, recently I undertook an assessment of employees washing their hands in water but not consuming the water with metals and what that actually means. And I also do human health risk assessments associated with contaminated land, example like gas works, pesticide mines. Another recent example of something a little bit different was a risk assessment in regards to an abattoir and the burial of animal carcasses being dug back up and the risk of anthrax and Clostridium. Also, asbestos-related disease from past exposures, trying to demystify the one fibre kills message, and obviously air quality-related public health risks, and so on.
Nathan, sorry to bother you. Just
Sure.
Your webcam is still on.
Okay. Thanks.
You.
Sorry, guys, I was looking over to the left there because that's where my slides are. Anyway, okay, back to the topic. Infrastructure developments are major developments like roads, airports, power stations, and the like are developed usually because we need them as a society, but they contribute to economic progress and make life a little better. There are obvious benefits to these types of developments, like getting people around more quickly and safely, generating power, providing resources. But often there's some risk to environment and health involved in their construction and operation. These developments, these infrastructure developments, will generally have to go through an assessment and decision-making process to help understand the extent of these impacts or the magnitude of these impacts, and if the whole project is of worth or of benefit to society in general. There we go. Environmental impact assessment or other types of assessments have been part of the project approvals process in most countries for a long time now. This process has been effective in predicting the potential adverse impacts of development projects on the environment and health. Part of this process can involve the conduct of human impact assessments to ensure that health considerations are factored into the early stages of the planning and decision-making process. The key area of health concern is, well, that's still on. I wonder why that keeps doing that. Sorry, guys. Pardon. A key area of health concern is outdoor air quality, and if a development is likely to have an influence on air quality, then potential health impacts should be assessed. But whatever the source or type of emission that may have health effects, it requires careful estimation of things like the area likely to be affected, the intensity and duration of the impact on the air quality, and the level of health impact on the at-risk population. Let's see what's happening there. I'm clicking. Okay, apologies, guys. There we go. There we go. Environmental assessment undertaken in the application assessment process for these types of developments are usually made up of a bunch of different technical studies and components, and they depend on the development type and the requirements of the agency making the decision. Here's just a couple as an example. Here we'll look at the air environment, social impacts, land environment, noise and vibration. Some of these feed into the health impacts. Yeah, just showing that there's quite a few components. Bit of a case study. We are currently looking at a project which is a proposed roadway development, which is in the reference design phase. It does require a health impact assessment to support the environment and heritage assessment report or the environmental impact assessment. The project is a combination of tunnels. It has a lowered and surface level motorway as well as overpasses and underpasses. The development is, the roadway is within a densely populated area and which has sensitive land uses such as schools, churches, community centres. We've been engaged, as mentioned, to supply the health impact services as well as a bunch of other of those components, and the outcomes of which will help inform decisions or influence the design. So there are adverse impacts. The design may be altered. Here's a pretty little moving image of a tunnel. Some of the key benefits of the project, as I just mentioned, are less vehicles on the local streets, less stop-start traffic, and less time spent in cars. But these changes in traffic movement mean changes in the way vehicle emissions are distributed throughout the local airshed. And one of these key emissions in regards to human health from vehicles is particulate matter, which leads us to the topic. So as a health scientist like me, as a health scientist, I'd like to ask a question, as other health scientists do, what is the relationship between exposure to particulate matter and health outcomes? So this is the traditional epidemiologic view. But for the decision maker, or the people making decisions on these types of projects, they're asking a different question. In general, they're asking, how will the development or the policy action impact on the health of the community, not just the exposure component of it? And to answer this, we need to start looking through the larger scenario and its different aspects. So this here is called the impact pathway paradigm, or the chain of accountability. This is a simple visual representation of the major factors or steps from development up here through to the health response. So the development or policy or whatever other action will impact, will change emissions, or will have emissions or reduce emissions. That in turn will impact the ambient air quality in the local airshed, which in turn will dictate the exposure and dose that the population impacted will adhere, and in turn that will impact the human health response. So as mentioned, there are other technical studies involved in these type of assessments, and air quality impact assessments are one of these. They use the air dispersion modelling to help inform this part of the impact pathway. And the outputs usually of the air quality impact assessment will feed into the health impact assessment down this part, this side here. So particulate matter. Airborne, well, particulate matter is a mixture of solid particles and liquid droplets found in the air. And some of these particles, like dust and smoke, are large enough or dark enough to be seen with our eyes. Other particles are so small that they can only be detected using electron microscopes. Particles come in different sizes and shapes, can be made up of hundreds of different chemicals. And there is a distinction between the sources of particles, and we refer to them as being either primary or secondary particles. Primary particles are emitted directly from a source, such as construction site, roadway, smokestacks, fires. Secondary particles, they form in the atmosphere as a result of reactions of chemicals like sulfur dioxide, nitrogen oxides, which are emitted from places, combustion usually from power plants, industries, and motor vehicles. So due to these different sources, the physical and chemical characteristics of airborne particulate matter varies by location and over time. Particle size is an important issue when considering potential health impacts. This image here shows size comparison for particulate matter. Particulate matter is usually described by its size. Here we have PM10, which is particles less than 10 micrometers or microns in diameter. You can see these blue balls here. A few of them can wrap around a human hair. Up here is these little red globes or balls or particles. They're PM2.5, and as you can guess, they are particles less than 2.5 micrometers, microns in diameter, and quite a few of them can stretch around the PM10. So yeah, particle size is important in regards to health. The larger particles are generally get caught up in the or trapped in the body's natural defenses. And as particle sizes get smaller, they can penetrate deeper into the respiratory tract, down to the bottom of the lungs, and even ultrafines will translocate directly from the lungs into the bloodstream and be distributed to other parts of the body. We're going for time, 10 minutes there. Oh, this is a bit of a lot of words on this slide, but what it's saying is that there's many health effects from exposure to particulate matter. There's been many studies now that have shown association between exposure to particles and some of these health effects mentioned here: increased hospital admissions, increased death from cardiovascular diseases, premature deaths. Now, short-term and long-term exposure is thought to have different mechanisms of effect, with short-term exposure appearing to exacerbate pre-existing diseases like asthma and chronic obstructive pulmonary disease, while the long-term exposures most likely cause these diseases or develop diseases and increase the rate of progression. So we know that exposure to airborne particles is associated with a range of health effects, but to what extent does the particulate matter cause these effects? How much does someone need to be exposed to, or how much does a population need to be exposed to show these effects? And this brings us to the exposure health effect relationship. There's been well over 20 years, probably 30 years or more of research on this topic. And despite that, there's currently no evidence of a threshold or a cutoff point at which exposure to particulate matter does not cause any health effects. And in science, so that means any increase in particulate matter concentrations and exposures will likely result in an increase in a given health outcome in the population exposed. And the epidemiological science has quantified these relationships as best as possible in what we term concentration response functions. As an example, one key study by Pope, I think it was, identified that an increase of 10 micrograms per meter cubed, that's the concentration, is associated with approximately 6% increase in all-cause mortality for people over 30 years. So this happens even below the guideline values, and there's no standard or guideline is completely protective of health. And that's one of the key messages of this talk, is that we can't just compare the exposure, the concentrations to a guideline. If it's below, oh, that's all fine. If there's been an increase, we have to understand that. And the tricky part is understanding the epidemiology and the other factors that we need to use to calculate what these health changes may be. So here's a very quick visual representation of this. On the left y-axis is airborne particulate matter concentration going up, increases on the over there, and on the bottom here is time. Let's pretend this is a guideline value, which is 8 micrograms per meter cubed, and this is city A or B or any location, and this is the background concentration before, say, a development or a policy or whatever it is that will impact the airshed. So as a result, the concentration and exposure goes up by an increase of, say, 2 micrograms per meter cube. Even though it's still this concentration is below this guideline value, this increase here will result in an increase of many of those health outcomes that I mentioned before, like exacerbation of asthma and hospital visits and increased mortality. So that just demonstrates you can't just compare it to a guideline value. So how do we know what that increase is going to be? It's a pretty mathematical equation, but the calculation of these changes in health endpoints considers these 4 elements. We use these 4 elements, so we need to understand what the changes in the particulate matter concentrations are. These are the incremental impacts or the levels in the airshed. How many people will be exposed to that increase in particulate matter? We also need to understand what the baseline incidence of the health endpoints. For example, 1,000. There might be 1,000 hospital visits per 100,000 within that population as the baseline. So that's the baseline incidence. And we also need to know and be familiar with the concentration response functions that we take from the epidemiological data, from the epidemiological literature. So the outcomes, using those 4 elements in the previous slide, they're used via a set of equations to calculate how many more people may get sick and what this is in terms of risk. So here's a typical example of a table that I might produce in a report. And this is the outcome of those calculations. I'm not going to go into this too much. Here is the maximum minimum increase in particulate matter for, say, cardiovascular hospitalizations, which is this sort of grey-blue one here, for people over 65. In this local government area here, which has a population of just over 100,000, there'll be 2 excess people hospitalized due to cardiovascular reasons at the minimum projected increase in particulate matter. Now, this information comes from the air quality impact assessment, the modeling, and at the maximum modeled, 4 extra people will visit hospital that year, will be calculated to, predicted to visit hospital that year. Another way that this information is presented, here's a graph. For example, here on the left-hand side here is the risk this time, not the actual numbers, is the risk. So this this means 1 in 10,000, 1 times 10 to the -4, and the different risk levels going down. The higher the bar here, the more risk there is. And this red line is what we would consider the acceptable risk. Now, acceptable risk is not something that science can really determine. That's based on the stakeholders, a lot of other factors. So acceptable risk, we found generally in the literature, generally in across a range of these studies, it ranges between 1 in a million to 1 in 10,000, but it's project dependent. And these are sensitive receptors. By sensitive receptors, it's locations such as schools, stadiums, colleges, as you can see along here. So it's just another way that the outcomes of the assessment can be presented, and this is projected to a 2031 scenario. This comes from the case study that I mentioned before. So with all science and assessments, I guess there's uncertainties and assumptions that we need to take into account when presenting this information. There are uncertainties in the air quality modelling. It's modelling, so it's not definitive. There's also uncertainties in the population data we use, so the number of people exposed and the incident rate for the health effects, the baseline incidence. That's collected usually by health agencies within the region, and that's not always and can't be exact. Then there's also uncertainties and assumptions that we apply or consider with the underlying studies, the epidemiologic studies, versus the actual exposure scenario of the project or of the project or the assessment under hand. So a lot of these studies may have happened in North American cities or European cities and at some time ago that have different characteristics to, say, a city in Australia. Even though they might be slightly different, there still is some differences. So we have to take into account these uncertainties. And also the components of particulate matter mixture are changing. It's changed due to technological advances. And here's an example of this. Oops. So this is a graph here taken from a 2019 report on UK emissions of particulate matter from road transport. If you look back here in 2000, so here's the years along the x-axis here, and here's kilotons. The blue is tyre wear. You probably can all read this. The orangey color here is brake wear. So these are particles being emitted into the airshed from these types of from these sources. The grey is road abrasion. So they're all sort of physical direct primary sources, and this yellowy color here is the from the exhaust. So as you can see, the exhaust trend is not as a larger component when we get around these areas here. Of course, this is projected through to 2030. So let's just say a study, the epidemiological study was undertaken back here in 2000, or even prior. The concentration response is based on a different exposure component. So when we project this forward, it's and we do our health impact assessment using information from the studies back here, we can see that as mentioned, the mixture of particulate matter is different, and usually these combustion particles are slightly smaller and may have more health impact effects. So in general, based on that, the assessments that we do are on the side of caution and probably overestimate the risks. So that case study, I couldn't give too much information on it because it's still a sensitive project, but we're just about to finalize the health impact assessment, which is based on air quality, not just particulate matter, but nitrogen dioxide, which is also a non-threshold pollutant, and also noise impacts, but a bunch of other air toxics as well. So the indications from that assessment is that the project will not result in unacceptable risks to health from changes in air quality. And this is primarily because there is going to be an increase in traffic due to population growth, a natural increase, except the traffic will now be redirected off the local streets, as mentioned before. The traffic will flow at speed meaning less emissions, and the emissions are captured and distributed higher in the atmosphere. They're captured within the tunnel and sent up the stacks higher up. So it's the ground level exposure concentrations are not as extended as once thought. So the key takeaways, I'm coming to the end of my talk now. Oh, we're at 23 minutes. Particulate matter is emitted or formed from many different sources. It is associated with many adverse health effects. There is no threshold. Guideline values are not truly protective of health. And assessing health impacts isn't just a cookie cutter exercise of comparing against guideline values. And with that, we'll open the floor to questions. Sorry, I went a little bit over there.
No worries. Thank you, Nathan, for your presentation. So again, you can log your questions in the question box on the GoToWebinar control panel, and also the presentation is available to download as a PDF from the handouts. I will start with the first question. How long does particulate matter stay in the air?
That's a good question. It depends on the size. It depends on the source and the meteorology of the area. But some can be hours, days, and some can be a bit longer. So it's there's not one answer for that. So that's the best I could do with that one.
No problem. Thank you. Do you assess risks for different types of particulate matter?
So different types. So I guess that's from different sources. No, not particularly, because the underlying studies that provide those concentration response functions, the studies looked at populations in the real world, and the real world, the particulate matter mixture is made up of various sources, and to untangle that at that point based on retrospective assessment is too complicated, and it's just not practical. You probably couldn't do it. So no, we don't differentiate in the assessment. It's applied to particulate matter based on its size. I hope that answers that question. No problem.
Another question: if guideline values are not truly protective, what are they used for?
Well, they are protective to a certain extent. So when the guideline values are developed, there's a bunch of other factors, economic, built into the setting of those standards and guidelines. They're also there for cities or areas to a target to get below, I guess, because then at that if an area is already above that guideline value is protective. I'm not saying it's not, but it takes into account all those economic factors and is still suitable for the area. They are also meant for the measurement of a city in Australia might have a bunch of air monitoring sites around, whereas as those guideline values, if we compare them using modeling, it's a slightly different situation. I hope that answered that question.
Yes, thank you. Another question here: are there any specific chemicals identified among hundreds of chemicals to have effects on respiratory or cardiovascular health, or both?
Yeah, there's quite a few, I'd say. You would have PAHs, a range, metals. So that the mechanisms, going back to that question before about the different particles, the toxicology gives you the mechanisms of effect. So we know that metals, particulate, polyaromatic hydrocarbons, and other toxics, we know their mechanisms via the toxicology. Epidemiology tells you the effect on the population. So I couldn't name some off the top of my head that directly impact those or cause those health effects that the question asked. But yeah, sorry, that's about as far as I can go with that one at this point.
No worries. This can be followed up later on by email.
Yeah, sure.
We don't have additional questions, so this is the end of the presentation. Thank you so much for joining today from all across the world. Thank you, Nathan, for this early start, and thank you for your presentation. Feel free to follow up with Nathan via the contact details shown on the screen, and have a wonderful day, everyone.
Thanks, everyone. Appreciate your